We now continue to session 2, program statistics. I will now open the program statistics editor, which will take a few seconds. The program statistics editor is a series of editors to accommodate the WHO data for TB burden and TB notifications, and also drug-resistant TB. The first editor is TB incidence. The data begins in 2002. That's the first year of publication by the WHO, and the final year is currently 2019. WHO will prepare now the 2020 data, which will be published in the end of 2021. This data can all be edited. If you have data suggesting a different TB incidence trend for the past, you can insert this data. Each data point has an upper bound and a lower bound, and there's a split between total incidence and HIV negative incidence and HIV positive incidence, and also for the number of HIV positive cases receiving ART. In the time estimates model, the incidence numbers and the split according to HIV plays a role in the calculation of mortality. This may not be your greatest interest when you do costing in One Health, but it should be mentioned here for the sake of completeness. The next editor is TB prevalence. WHO does not currently publish TB prevalence trend. We have a point estimate in the model that we use for different purposes, but it is typically not used at all by the One Health user, so you can ignore this estimate. The most important editor for One Health costing is the TB notification editor. Here we have data starting in 2000 and ending in 2019 for total TB notifications. The 2020 notifications will be published also at the end of 2021, and this whole default database will be updated from WHO data at the end of 2021. So we have total notifications. Then we have, importantly, the split of total notifications into different case types. So, for example, into pulmonary cases or extrapulmonary cases, or into children. All of these splits play a particular role in costing. For example, when we cost methods for testing for bacteriological confirmation, diagnostic methods, we have to know this number. This is the reason for this editor. The forward projections from 2020 to the final year of the projection is based on the 2019 proportion of these case types relative to the total. You'll notice that there is a projection of TB notification. This is a default projection that is available in the model, and we will replace it shortly with our own model projection of total notifications. We do not show the historical data for these case types because WHO changes sometimes the definition of cases, and not all of these indicators are available for many years, or at least not for enough years for us to produce a separate projection for each indicator. So the approach here taken is to work with total notifications and to apply the 2019 case split. The user can edit this case split by using this option up here called Enable Editing of Absolute Numbers. And now these numbers can be edited directly. But it should be noted that the user should be careful that these totals add up to the total notification type. Another way to edit this case split is through this editor called Enable Editing of Percentages. It's the same editor, but here the case types are expressed not in absolute value, but as a percentage of total notifications. So here the user can edit these numbers, these percentages, but again, should pay attention that they add up to 100. For these ones here should add up to 100. That's correct. The ones that can be edited should add up to 100. And the user may do this for different reasons. For example, it may be an objective of the national strategic plan to increase the proportion of cases that are bacteriologically confirmed, or to increase the proportion of pediatric TB cases. So there may well be reasons why these proportions are expected to change. And if the user has information on how they are expected to change, this information can be entered here. The next editor is HIV positive TB burden. HIV positive TB is measured in three ways. We have surveys, population level surveys, or we have TB testing in HIV sentinel settings, or HIV testing in routine TB testing settings. Each country collects this data in different ways, and it is reported to WHO and published in a database, and we read it from that database. The reason why we need this data is to produce the split of TB incidents into HIV and HIV negative and HIV positive. This split plays an important role in the calculation of mortality, as we will explore in a minute. And also here at the bottom, we have among the HIV positive TB cases, the proportion receiving ART, and among those, the proportion that have been receiving ART for more than 1 year. These elements are all important for mortality calculation. We will return to this point in the next session. The next editor is drug-resistant TB care, and this is arranged in three parts. First is the statement of resistance burden among new pulmonary cases and retreatment or previously treated pulmonary cases. The data for the future post 2019 to the final year of the projection is not important. We do not use the trend. We only use the 2019 data point. We also don't show data for the past because WHO does not report trends in MDR, so we do not show that data. But the user should focus on this percentage of new and pulmonary cases that are expected to be RIF resistant. Then we have DST. What is the coverage of DST? What proportion of bacteriologically confirmed pulmonary cases, new and previously treated, have received a RIF resistant test? We calculate this number by default and use it to produce a kind of a trend of DST. The past value is really not that important. The future values is used for costing. So the user should pay attention to those future values. For the moment, until the user edits the value, we will simply use the value in 2019 to calculate DST coverage, which is used in One Health costing, as we will see. And finally, we have the treatment component. So among the new cases and previously cases, the number that initiated MDR treatment. This is needed. We project this forward, and we need it for costing of MDR treatment in One Health. The next and final editor of program statistics is active screening and TPT. We have three types of TPT settings in this model. First one is about contact tracing in households. And the next one is high-risk TPT in high-risk groups and ART patients. For each of these groups, we need to understand, first of all, the size of the population that might be screened for either latent TB or active TB. And for that size, in the case of households, there are parameters that define the size of the household of the index case and the proportion in the household that may be children. And within this population, we also need to know the prevalence of latent TB, of active TB, and latent TB. And we have to know it separately for under 5s and adults, because when we do the TPT calculations, they may receive different diagnostic approaches or different regimens for TPT. So for each of these three populations, households, high-risk groups, ART patients, we need to know this prevalence of active TB and latent TB. And that role will become clear when we do further costing work for TB prevention. In the household case, there is a setting here at the bottom called proportion of bacteriologically negative contact screened. In many countries, it is only bacteriologically positive contacts that are screened, for example, for latent TB or for active TB. But the user may also state the proportion of bacteriologically negative contacts that is screened. There are many such situations where countries also screen the contacts of bacteriologically negative cases or cases that are not diagnosed as bacteriologically positive, for example, clinically diagnosed cases. So this information, population size, prevalence of latent TB, and prevalence of active TB needs to be specified. We provide default values for these, and in the guidance document, there's a detailed description of where this default data comes from and also what it means and what the formula is for calculating the eligibility for preventive therapy. Then there is a series of settings that the user has to specify. The first one is the proportion of these suspects that are evaluated. So this can be seen as, for example, the proportion of households of infectious cases that are screened. Currently, I have values here because this is a demonstration file, but by default, that value would be 0, and it's up to the user to define what proportion of households are screened. Then within the household, we deal separately with children under 5 years old and children and adults over 5 years old. And the reason for that is, first of all, that they may have different testing approaches for latent TB, if latent TB is being applied. The first setting in each group, though, is stating if preventive therapy is given presumptively meaning without any screening for latent TB. In many settings where there's very high risk, in resource-limited settings, cases could be given preventive therapy presumptively. In this example, I'm stating that 70% of suspects are given preventive therapy presumptively, and among the remaining 30%, 100% of them will then receive tests for LTBI. And the tests that are used are stipulated here. The user has to specify this proportion of the cases that are tested by each of the main methods stated here. In One Health, when the costing is done, the user must also state that same proportion of different tests that can be used to test this case type. And for those who are eligible following testing, and those who are eligible presumptively, there is a setting to state of everyone eligible what proportion is then linked to preventive therapy. So in many cases, that might be 100%. That's the whole purpose of evaluating the household and the suspects, but it may not be always the case. And it may be a part of the strategy to increase that to 100%. The settings for adults, children and adults over 5 years, very similar. Same logic. First, specify what proportion is given preventive therapy presumptively. Then, among those not given preventive therapy presumptively, what proportion are tested. If the value is 0, then that proportion of suspects will just not receive preventive therapy at all. And their method mix for testing and link to care. And then finally, among the cases, the suspects that are screened, what proportion will be screened for active TB? It may also be that in many cases, a significant proportion of these suspects will also be screened for TB, and the user must enter this value here, as well as the proportion of those that are linked to actual TB treatment. And these settings are very similar for high-risk groups and ART patients. I will next discuss those. Finally, now that we've talked about active TB screening, there is another editor where the user has to specify the average sensitivity and specificity of the active TB test. The reason for this is that it may be the case that specificity is not 100% in a particular setting or in a particular country. And if it is not 100%, then there will be a proportion of false positives that emerge when cases are screened for TB. So at the moment, the default assumptions here we use is that sensitivity and specificity of the test is 100%, but that may very well not be the case. For example, it is not the case when smear microscopy is used. Many methods don't have perfect sensitivity and specificity. So the user needs to evaluate if this is critical to know what proportion of the screen cases might actually be false positives, then the user has to specify the true sensitivity and specificity. If this distinction is not important, then the user can just use these default assumptions of 100%. We move now on to screening in high-risk groups. First, here we specify the proportion of the total population that will be found in high-risk groups. And this high-risk group is a representation of all cases outside of households and outside of ART and not ART patients that we consider at high risk for TB infection. So these could be people suffering from diabetes, or other close contacts not found in households, or people exposed to silica like minors, who are all at high risk of TB infection. We stipulate the total proportion here, but notice that this is now the proportion of total population that will be screened. So it can potentially be a very large number, and the user and in typical settings, that proportion that actually will be screened or evaluated is quite small. And similarly, into the household contacts, we need to know the prevalence of active TB and latent TB in children under 5 years old and adults and children over 5 years old. Again, these prevalence values are needed to estimate the need for TB prevention and also the need for active TB treatment. And both these elements are used in the calculation of the eligibility of TB preventive treatment and of active TB treatment. These calculations are explained in the annex of the guidance. And similarly, the settings, exactly like it worked in the household case, we have to specify what proportion of this special population that we've identified will be screened. So here I have an example where they will all be screened by 2025, for example. Again, we have to state among children and among adults separately who will be receiving preventive therapy, what proportion will receive preventive therapy presumptively, and what proportion of the remaining cases will be tested for LTBI, and only after testing will be eligible for TPT. Again, for those tested, there is a method mix that has to be specified and which should also be matched to the method mix in One Health, which we will look at in the next session. And then finally, the proportion of the eligible cases, either presumptively or via testing, that will be linked to preventive therapy. Ultimately, through this cascade, the final number here that are linked to treatment is the target population that we will be using for costing of preventive therapy, the treatment part of preventive therapy. And similarly, we finally at the bottom here have to specify what proportion of these cases are screened for active TB, and among those that are found, using the prevalence setting of active TB here, among those that are found, who will be linked to treatment. And because we have active TB screening, we again have the sensitivity and specificity settings to be stated. Again, the default assumption is that sensitivity and specificity is 100%. If it's not 100%, it influences For example, the number of false positives. Again, if this is not of interest to the user, can be ignored, and we can keep the settings to 100%. Finally, we have preventive therapy for ART patients. It works very much like the editors for households or for high-risk groups, except that we have a split here between new ART patients, 0 to 6 months, and established ART patients, more than 6 months. The reason for this is the approach that countries are following for TB, TPT among ART cohorts is to focus strongly on providing TPT to new ART patients and also to catch up in the existing cohort of ART patients. But over time, most ART patients would then have received TPT, and we will just give TPT to the new ART patient. And in this way, the whole cohort of ART patients will eventually have received TPT. So each country has a different approach, how much catch up they want to do in the existing cohorts. But we have to specify again the prevalence of active TB and latent TB in children and in adults in these ART both cohorts, 0 to 6 months and greater than 6 months. Once that's been specified, and notice that we don't need to specify anything related to the size of the ART patient, and the reason for that is because the size of these two cohorts for children and adults come from the HIV model here, which is the model that each country prepares working with UNAIDS to estimate their HIV burden and to supply information on ART. The screening and TPT settings editor look exactly the same as it does for households and for high-risk groups. Here we have to specify what proportion of these patients will be evaluated. In other words, will enter the TPT cascade. Then again, we have to decide who will be given TPT presumptively, who will be tested for LTBI before they are eligible for TPT, and among everyone that's eligible, who will be linked to treatment. Same for similar editor for children and adults over 5 years old. And there's one section for new ART patients, and there's one section for existing ART patients. In this editor, we do not have active TB screening, and the reason for that is simply that we treat the HIV proportion of notified cases as part of the split in notifications that will ultimately come from the processing of the TB incidence data and the HIV TB burden data. So this is all part of the routine testing program, and this active screening is typically not the approach that in ART cohorts is typically not the approach by which TB is found in ART cohorts. So for the moment, we are treating HIV as part of the overall split of TB notifications and not as an active screening approach. This is something we may change in the future if we have clarity on how this should function. So these are all the editors of the program statistics. In summary, we have data for incidence. We do have data for prevalence. It's not that important. TB notifications, HIV, the data used for the HIV-TB split, data that's used to estimate MDR burden, DST, and treatment volumes, and then quite a lot of editors related to TPT. And WHO provides data for many of these indicators between 2000 and 2019. Later in this year, we will receive data for 2020, which will then automatically be loaded into this One Health software. Some of the editors we do not need past data or future data, like, for example, MDR burden data. And this data related to TPT, we receive no data from WHO. This is not routinely collected or not in the form that we can use in these editors. So the whole TPT program has to be defined by the user in terms of who is eligible and under what, basically how the cascade towards TPT eligibility works. Is it based on presumptive treatment? Is it based on testing? what proportion is linked to care. So the whole nature of the cascade has to be specified separately for children and for adults. And it has to be done separately for households, high-risk groups, and AOT cohorts. So that concludes the discussion of the program statistics. We will now proceed to the next session, which is about model fitting.